Welcome to The Disappearing Mind, a unique podcast helping you find clarity and support along your dementia journey. Now, join National Dementia Trainer and Coach Dawn Platt for an all-new episode.
Welcome back to the Disappearing Mind podcast, where we bring real conversations, practical tools, and compassionate perspectives to those navigating the journey of dementia care. I'm thrilled today to be here as your host, Dawn Platt, and to have an author on the podcast today. We're going to delve into the dementia journey. I'm thrilled to have a very special guest, Dr. Brent Forrester, who is a geriatric psychiatrist and dementia care expert, along with his co-author, Thomas Harrison. Dr. Forrester wrote The Complete Family Guide to Dementia: Everything You Need to Know to Help Your Parent and Yourself. A resource that has been described as relatable, practical, and deeply validating for caregivers. We'll be talking about the realities of dementia, the challenges of shifting family roles, and practical strategies for caring smarter, not harder. Welcome, Dr. Forrester, to the podcast.
Thank you so much, Dawn. It's a pleasure to be here today and speak with you and your audience.
I'd love for you to share what inspired you to write this guide.
So, as you mentioned, I'm a geriatric psychiatrist. I've been in the field for almost about 30 years now. And for the entire time that I've been a geriatric psychiatrist, the area of my work that's been most interesting and challenging has been caring for people with various forms of dementia. And especially working with their families. And I think that what I've noticed over time is how much families struggle with caring for their loved ones in so many ways. That the disease of dementia is really a family illness. It's not just affecting the individual with a problem. And I often felt after a clinical encounter with a patient, their loved one, whether it was a spouse or an adult child, that I wish I had something to give them to take home. Because I felt like a broken record after a while, repeating the same guidance and advice. And I knew that they weren't going to remember this, and I didn't have handouts that I could give them. It really was the relationship that I developed with them over time, and the fact that they knew that they could call me and go over the challenges that they were facing. And I felt like, oh my goodness, how do I scale my expertise and really help more people? And then one day, and I thought about doing a book years ago, but of course, never got around to it, given other obligations in my academic and clinical career. Then about 2018, 2019, a colleague of mine at McLean Hospital, where I was working at the time, introduced me to Tom Harrison, my co-author. And Tom said, look, I've got a mom with dementia that I've cared for, and I've been working on this manuscript, which I really see as a guide, a very practical guide, a guide that's really not out here yet in the marketplace for families. That really takes family members through the journey of dementia care, from diagnosis to the end of life. And what was brilliant about Tom's approach, I think, in the way he's thought about this book, is that it really provides practical guidance on what families should know and should think about doing and should do that no one tells them to do, where you can't really find it anywhere else unless you're working with an expert in the field. Like a care manager, social worker, maybe a dementia navigator, various kinds of roles, people who are out there who really understand how to support and work with families. So that's kind of the long story. And I do feel handicapped today. I got to be honest with you, not having Tom by my side, because we often do this together.
Well, I know that you're not going to be handicapped. We're going to walk through this together. But you just made a comment that as a dementia coach, I hear from families all of the time, and that is, we don't know what to do. We don't have the answers. We're not hearing what we need to hear from our doctor, from our professionals. What do we do? So I'm so glad you brought that up. But before we dive in a little further, for the sake of my audience, what is a geriatric psychiatrist?
I'm glad you asked that question, Dawn. So I was trained, a geriatric psychiatrist goes to medical school for 4 years. then chooses to specialize in the field of psychiatry, which is another 4 years. Part of that training includes neurology and internal medicine. And some of the experiences that we have in residency include working with older adults. And my own personal journey is that not only am I a third generation psychiatrist, so I kind of have it in my genes and my environment, but in medical school and in residency, I was most taken with the world of medicine, psychiatry, and neurology, and the way they come together in understanding how a person thinks and how they behave and how they act and how it impacts the world around them. And I felt that geriatric psychiatry with older adults is really the one area where those three fields of medicine come together: medicine, psychiatry, neurology. And so then we go on and we do a fellowship, and we do a fellowship for 1 year, trained in caring for older adults with mood disorders like depression, with anxiety, with substance use disorders, with neurocognitive disorders or dementia. And we learn a lot about how to care for them in every manner of situation that they find themselves in, such as in home care situations or in long-term care situations, or when they're living at home with loved ones, when they come into our offices, or when they need to be hospitalized because their depression's so severe they don't want to live anymore, or because they've developed the delusions that people aren't there, or they develop problems with thinking or memory that are actually caused by dementia. So that's what a geriatric psychiatrist is and how we're trained. And then I could go on and on, but one last point to make. In the United States today, we're training a total in a good year of 50 geriatric psychiatrists for the entire country every year. And think about how many millions and millions of individuals are turning or above the age of 65. And that number is only growing day by day with the aging of the baby boomer population. So this is becoming a real challenge. How do we take people with expertise like we have and help care for a larger part of the population? And that's something maybe we could get to as we kind of go through this.
Wow, that is a very low number, a statistic that's kind of shocking, but probably the reason why I don't know too many geriatric psychiatrists. So thank you for what you do every day. But we know that Mr. Harrison was a journalist or is a journalist, and he had a family member with dementia. But how did your two blended backgrounds kind of guide or reflect in how this book was written?
So at the time we first started talking, Tom's perspective was having cared for his mother and seeing his mother's challenges that were not just related to the memory loss, but were especially related to day-to-day functioning and behavior. And the behavioral issues he and I have talked a lot about, because oftentimes it's not the memory loss, it's often the agitation or the depression or the paranoia that's driving the burden of this illness, not only for the individual with the illness, but also for their family. So we shared that perspective. Tom brought this really interesting, unique perspective, which I have not heard anyone really describe or communicate before, but I think gets into another area where we spend a lot of time talking through, and when we get together and speak to public audiences, we often focus on, which is how dementia is different than every other illness. And that is a message that's very clear in this book. And it really is something that is reflected in my thinking now, having worked so closely with Tom. And that the ways dementia is different than every other illness is that, for the most part, it begins extremely gradually and very subtly. And there's also this tendency for people who are living with loved ones who are developing dementia to either not notice it at first, or to write it off and dismiss it as, oh, mom's getting a little older, or my spouse is, maybe it's age, And so we often attribute some of the earliest signs of this illness, which is a degenerative condition and essentially will proceed to death at some point, as something that doesn't have any urgency, that it's just normal aging. And there's a big difference between normal aging and dementia. And we can kind of go through that. So Tom and I spent a lot of time thinking about this reality of there's no urgency on the part of the family. And then my perspective is there's no urgency on the part of the medical community. because most of the people caring for folks with dementia in the medical setting are not specialists. Because, like I just said, there's so few geriatric psychiatrists. The other two specialists that deal with dementia in an expert way are neurologists, behavioral neurologists in particular, cognitive neurologists, they're sometimes called, and geriatricians, folks who work with the older adult population, internal medicine docs who become geriatric specialists. And each one of those disciplines approaches dementia a little bit differently. So we don't have that same holistic approach to dementia yet. And I'll talk a little bit what we're doing here and now at Tufts, where I work, but a holistic approach to dementia care, which, by the way, we have for cancer. We don't have that for dementia yet, except in rare cases. And that's part of the reason why families don't have the guidance they need in what to do with the journey. So Tom and I talked a lot about how when his mom was diagnosed, where does he turn first? Where does he go for a workup to have his mom evaluated? And then if she's diagnosed, who is going to guide them from there, step by step, and what comes next? And so he and I spent a lot of time thinking about that together. And Tom's got an incredible writing style that can explain complicated ideas and topics in very simple ways. And it was really the early days of the pandemic that he and I were going back and forth on Zoom and email and all nights and weekends to get this done. And it really became for me, it was certainly a labor of love.
A passion.
Yes.
You can tell that you're passionate. When you think about the reader, who do you picture reading this book?
Anybody who's got a loved one or a friend or someone they care about who's suffering from either diagnosed dementia, and they know there's a problem. Alzheimer's type is the most common type of dementia, or the earliest stages of that we call mild cognitive impairment, somebody with a memory condition due to an underlying brain disease that may or may not be the Alzheimer's type. But anyone that in the family or the close-knit circle of someone with dementia, this book was written for you. And if you take a step back, and I think about when I talk to a general public audience or a primary care practice, as I've done twice this week already, or with my students and my trainees, if I take a step back and I said, forget the fact that you're a clinician, how many of you in this audience have a loved one with dementia of some kind, a family member, or they know of someone who's got this? And almost, I would say 90 to 95% of the hands go up. This is a pervasive condition. 7.2 million Americans. Half of those, not even diagnosed. And the half that are diagnosed, get diagnosed after the horse is out of the barn for years. And someone can no longer pay their bills or drive. And there's an obvious problem. And then it may or may not get diagnosed. And so we talk a lot in the book about the reasons for the delay in the diagnosis. So this book was written for adult children of loved ones with dementia. It was written for spouses of someone with dementia. It was written for grandchildren. But really, the perspective Tom has is being an adult child. Now, I'm also an adult child of a mom who's got early signs of mild cognitive impairment and challenges of aging in both of my parents, so that my own caregiver experience, which has been intense to say the least over the past 2.5 years, is now reshaping the way I think about myself as a doctor who cares for older adults. And I'll just share one other little thing, which is that for years, caring for folks with dementia and helping their families, I thought I really understood what it meant to be a caregiver, because I had thousands of people telling me what it was like, and I listened a lot. But until you're a caregiver yourself, you have no idea the burden of living with this illness. You have no idea the complexity and the challenges of trying to manage day-to-day life. And then in the earliest stages, when they're doing pretty well, of course, there's a lot of denial and minimization about what the future may hold. And well, why would you want to galvanize around a problem that may not be 5 or 10 years from now until it's really weighing heavily on me? That whole comment you made, the comment you made in the earlier part, which is a mantra in our book, which is to be proactive instead of reactive. That needs to start on day one when you see a problem, not 5, 10 years in when there's a crisis. The whole point of being the proactive is to minimize the crisis, to be prepared for the crisis, which will inevitably occur. And there are things that you can do to mitigate the chances of that crisis. So I would say this book is written for a very wide audience, but it's really for caregivers at spouses, adult children, grandkids, or other loved ones.
I would definitely agree with that. You mentioned earlier that dementia was a family disease. Do you want to talk about that? Especially now that I know that you are both sons, which is very, very unique. And by the way, I am a daughter. I lost my mom about a year and a half ago to vascular dementia. Everything I knew in my 30 plus years of working with people with dementia as a coach, as a clinician, kind of went out the window. So I could totally relate with what you're saying, but what do you mean when you say dementia is a family disease?
There's so many aspects of the care for people with dementia that really has highlighted to me how much of it is a family disease. First of all, from the clinician's perspective, if I see somebody who's aging with a memory problem and I evaluate them and I got no information from the families to tell me what's going on, I essentially have no idea what's going on. I mean, I can do a clinical assessment and come to some guess about what I'm seeing in front of me now, but I don't know the story about what's led up to now. And families do. Families live with this. They live with their loved one. But one of the first things that happens that I think is challenging for families is that the person who's experiencing the symptoms may or may not know they have the symptoms. If they know they have the symptoms and they're worried and they're anxious about the symptoms, that will impact the family because anxiety in the loved one will provoke anxiety in the family member. And if the person with the illness is unaware that there's a problem, that will also provoke not only anxiety, but somewhat confusion in a family member saying, well, how am I going to cope with this? Because I tell them something I just told them 5 minutes ago and they don't remember it. And they're not aware that they're not remembering it. And I'm getting very upset and anxious and agitated. So when I say it's a family illness, it's that the family is deeply impacted emotionally by the fact that their loved one was going through this. And it's changing in some ways the nature of who that person is and was. It may change aspects of their personality and their behavior and the way they even speak, their language and communication skills. All of this will deeply affect the relationship between the person with the illness and the loved one. So that's a big part of it. It's the emotional aspect of the family interaction with their loved one. But there's also the practical part of it, which is that as the disease progresses and the impairments in day-to-day living become more challenging, or the behavioral symptoms escalate, or the person is really unable to be safe alone, who's in charge of making sure that person's getting the care they need and being safe? It's the family. And luckily, maybe you and I were in families. We're in families where we came together, and at least in my case, my siblings and I, and working together with a care manager and a coach like you and others to really support my parents. But not every family has that, and so that's one of the points that we make in the book is that we really want to educate families because we know it's deeply impacting them emotionally. It's impacting them from a day-to-day functioning standpoint, like how do we organize this? It's going to impact them from a financial standpoint because insurance pays for very little of the care that's needed for someone with dementia. Of course, it'll pay for a hospitalization. If a person falls and breaks their hip with dementia, it'll pay for skilled rehab like it would with anyone. But it doesn't pay for a home health aide. It doesn't pay for a dementia care manager who can coordinate and orchestrate a lot of the care and the support that's needed. And it certainly won't pay for an assisted living memory care facility where a lot of people with dementia who have means really require care because of safety issues and because of quality of life issues. So on almost every imaginable level, this is a family disease. Oh, one other thing I didn't say. The other reason I say family disease is because a loved one caring for someone with dementia is themselves at higher risk of suffering medical complications, like an acute heart attack, for example, from the stress and other factors that may impact them physically. And then the emotional impact of it, which I alluded to, is not just feeling stressed. It's clinical symptoms of major depression or an anxiety disorder, which are extraordinarily common in caring for a loved one with dementia over the course of the illness. And so paying attention to your own experience as a caregiver and making sure you're getting the help and the support you need will not only help you, but it'll help your loved one with dementia. That is another reason why this is such a family effort.
You bring up such an important point, and something that we see often over our careers working with people with dementia is that caregiver doesn't take care of themselves. Do you, in your practice, do you work on that? Do you coach that family, that person to really take care of themselves? I mean, after all, if something happens with them, who is going to make the decisions? I think it's such a common stressor. Often in my career, I have seen, even in my own family, someone take care of a spouse. And then when the spouse, engages in the last stages, the caregiver is often ill themselves based on not taking care of themselves over the number of years that it is taken to care for this person. Do you help with that? What do you advise in that area?
Well, this is a great question. And I think you're going to see, if you take a loved one to see even a specialist with dementia, they may or may not address this issue head on. But I address this issue as a psychiatrist, as someone with experience dealing with this, is now experiencing it as a caregiver. I address it head on. And the way I approach it is, well, first of all, I recognize that every caregiver is experiencing this differently. I don't assume anything. I think sometimes clinicians assume, based on pattern recognition, that, oh, I've seen this before. This is the playbook for this problem. Everyone has their own individualized situation. And the other thing I appreciate as a psychiatrist that a neurologist probably won't, and a geriatrician probably won't, is that as a psychiatrist, I understand that the caregiver's prior history of their own mental well-being, so any prior history of anxiety, depression, addiction, PTSD, whatever, their prior history, and also their relationship with their loved one with dementia, both of those issues will directly impact the experience of the person is having as a caregiver. And you will have to meet them where they're at as a clinician. I've had some adult children, but I see this more in spouses, because a spouse is way more emotionally connected to the day-to-day. They're physically and emotionally connected to the day-to-day. They may not see the problem as quickly as an adult child who sees them less frequently will see it. And they also, some caregiver spouses will feel that this is their life work to care for their loved one. I took this vow 50, 60 years ago, 40 years ago, to be there till death do us part. And they're not seeing the impact it's having on them. I see this in particular. I see it with both women and male spouses. It happens with both genders. And it's really interesting. I've actually had the experience where a caregiver's come back to me and they've said to me, when you told me that if I don't take care of myself, I may die before my loved one, that was a wake-up call. And I don't use those words, but that was what they heard. And I do think I communicate that message very consistently, which is that part of my job in working with your loved one with dementia is to help you help yourself. And that may mean I need to get you into treatment with someone because you've got a clinically significant syndrome related to caregiving. Or it may mean that I need to send them to a coach like you to help guide them every step of the way, or perhaps to a caregiver support group. And what clinicians have to be careful about is not only to realize that every individual is an individual, but they do sometimes get frustrated or project their own sense of anxiety and frustration with the situation. Like, why doesn't this person see what I see that's obvious in front of me? And it's because the caregiver's perspective is going to be different depending on their relationship, their own issues, and the circumstances in which they find themselves caregiving. So I think it's highly individualized. I believe clinicians, it's part of our job to address it directly. I don't think it's done well in the medical community consistently.
I totally agree with that statement. In the first section of the book, you really talk about understanding dementia. You talk about the difference between dementia and aging, but how do you advise families who maybe struggle with the uncertainty of the diagnosis? How important is getting a diagnosis, in your opinion?
It's critical. And if you think about it, if you've got a loved one who's got chest pain and shortness of breath that comes and goes, and they're a little distressed by it, but it's not there all the time, you're probably not going to ignore that very long because you know it might be a heart attack. And you don't want it to be a heart attack because you don't want them to die right away. There's urgency to that. Caregivers are on top of that. People with these symptoms are often on top of that. Cognitive decline, memory impairment related to dementia sneaks up on you over the course of years, and it may not cause functional impairment for years. It may not cause a safety problem for even more years. And so there's no urgency there. So I think it's really important to know what it is that you're dealing with. If it is normal aging, which, by the way, I'm not sure I could really tell you a great definition for normal aging, because the more we're learning about the biology of dementia, the more we're seeing the changes in the brain that are early signs before it's dramatically symptomatic that there's something not right in the brain biologically. You know how like there's different severity of diabetes, there's different severity of heart disease, there's certainly different severity of cancer. Everyone knows this from their own experiences. Well, there's different severity of dementia. And the earliest stages, even though it may not be causing a safety problem or a major behavioral problem or trouble with driving yet, it's important that we're on top of what's going on and that we know what's going on, because there's so much we can do for people with dementia if we know there's a problem. And if we don't know what there's a problem, we're going to act and react in ways that might not only be not helpful, but could be dangerous. They may go on medications that are dangerous if they have dementia versus if they're not on dementia. And loved ones may say, Mom's just getting a little forgetful, and before you know it, they've drained their life savings because of bad financial decisions, which, by the way, may be one of the earliest warning signs that there's a serious cognitive problem. So getting a diagnosis is critical. And having said that, it's not easy. And the reason it's not easy is because how many of your audience goes to their primary care doctor at any age complaining of memory problems, and that primary care doctor has an exact algorithm of how to assess that cognitive complaint and how to evaluate it. And then if they think it might be dementia, are they comfortable even telling you what it is? Because they themselves have not been educated enough in this, and they don't feel comfortable making the diagnosis. We screen for cancer types all the time. We screen for diabetes. We screen for heart disease all the time. And by knowing the risk factors, we now treat people with lipid-lowering drugs like statins. We put them on medicines for diabetes. We do things to prevent heart attack and stroke all the time. And if we find cancer early enough, it's extraordinarily treatable most of the time. If we could find dementia earlier enough, the way we could impact people's lives is immeasurable from today's standards, because we're not doing it consistently. There's a lot of dementia prevention opportunities, or even decline, the rate of decline, the interventions that we can do early on to slow decline, improve quality of life, and improve outcomes for patients and their loved ones is huge, but it starts with that diagnosis.
One of the most powerful parts of your book, and probably something that has impacted, me very deeply, is you talk about your new relationship with your parent, or let's even say spouse. Can you unpack that? I know that I went through that. Your co-author probably went through that, and you may be going through that now, but unpack that a little bit so that we can understand that better. I think that's one of the hardest things that I went through as a daughter. What does that mean?
First of all, everyone experiences this very common phenomenon where the nature of our relationship with their loved one, with their parent, their spouse, it changes. It's impacted by your own experience and your own relationship with that parent or spouse over many, many years. So that will inform this to some degree. But it also becomes the case that, let's just use the adult child like you and I, like I am and you've been, where you've got a parent now who's not really able to make decisions the way they were before. And you're put in the uncomfortable position of being the one who really sees what's going on and they don't see what's going on. That could be around whether it's safe to drive, or that could be around whether they can actually pay their bills on time or not, or do it effectively. So you wind up in a situation where you kind of have to take over making decisions, and that may not be comfortable because you still feel like they're your parent, and they are still your parent, and they can still give you guidance and advice about life. And two things can be true at the same time. Your parent may not be able to drive anymore, or to pay the bills anymore, or to make really good decisions about things that they're doing or saying or behaving, but they still know who you are. They're still emotionally connected to you. They still may actually remember a lot about when you were growing up and what the relationship was before. Again, depends on the time of the illness. So navigating this very difficult situation emotionally where you're having to almost, and again, you hear this all the time, and I have experienced this directly, where all of a sudden you've become the parent of your parent. And it's a bad place to be in. It's a bad place to feel like you're in. I had this situation with my dad 2.5 years ago when he was in a hospital with a lot of behavioral challenges related to medication mismanagement, related to psychiatric symptoms. And remember, my dad's a psychiatrist who even now today at the age of 86, by the way, he and I talk about this all the time, and he knows that I talk about this publicly all the time. But at the age of 86, he still has some patients that he follows. And a couple of years ago when he was in the hospital, and I walked in to see him and I was asking questions, he said, "I need to tell you something." He said, "I feel like you're treating me as if I'm one of your patients." And we knew exactly what he was talking about, because I was. Because I actually, my brain unconsciously went into doctor mode with my own dad. And frankly, it's been in doctor mode with both my parents for the last 2.5, 3 years now. It's a really uncomfortable feeling to be in. It's one thing to feel like you're parenting your parent, but it's really another to feel like you're doctoring your parent, which you should never do. And so the one thing that I've done very consciously and very proactively with both my parents in the past 3 years is I have purposely not put myself in the role of being their doctor. I've made sure that I hand this off to the medical team, and they may look to me because of my area of expertise or whatever. One psychiatrist told me recently, it was in April, I think it was, so maybe 6 months ago, and my dad was struggling at that point, had to go back in the hospital. He developed a delirium from a urine infection, and he was seeing things that weren't there, and he was agitated, and he was combative. It was horrible. And he said, "Well, what do you want me to do with his medication?" And I said, "Why are you asking me that?" I said, "I'm not the doctor, you're the doctor." He goes, "Yeah, but you do this for a living." I said, "I do, but this is my dad. I don't want to cloud my judgment here. I'll give you guidance and advice. I'll try to be objective." So I know this is an unusual situation because most people caring for their loved ones are not physicians or nurses or in the medical field and do this all the time. But it's an example of how hard it is when you're having to take on a new role with your parent that doesn't feel comfortable.
That new role, especially when it comes around taking the checkbook or the car keys or anything like that, comes with so much guilt. How do you address that? I know you must have to address that, setting boundaries, and how do you advise them in dealing with this guilt? Because after all, we're doing what's best for them. You know, we wouldn't let my 3-year-old granddaughter walk out in traffic. So I certainly wasn't going to let my mom, scrape another garbage truck. How do you deal with that? How do you, talk to our audience about that guilt and setting those boundaries when it's really best for their loved one?
So one of the most powerful experiences caregivers have is when they finally get involved in a support group and they realize that they're not alone. Because many people in struggling with caring for their loved ones think that they are doing this and it's a one-off, that no one's ever experienced this. It turns out millions of Americans have experienced this, millions and millions. And I don't think there's one piece of advice to give around the car key issue or the checkbook issue. But when you get a bunch of caregivers together in a room led by an expert group leader, which, by the way, the Alzheimer's Association runs these and many clinics run these support groups. If you get a caregiver to say, "Yeah, I'll go to the group," they're going to learn so much from one another because there's so much creativity involved in how they've approached it. The other thing I really want to say is I feel very strongly that the decision around driving and the implementation of stopping driving really should be shouldered by the clinical community. And yet that is the exception and not the rule. Very few families have ever said to me, oh, my primary care doctor helped me deal with the driving issue, right? It's because number one, every state deals with this differently. So some states, doctors are mandated reporters around driving and others they're not. And then the other thing is many doctors don't feel comfortable addressing this as well, because a lot of primary care doctors have had 20, 30, 40-year-old relationships with these patients as well. And they feel like their family after a while. And they also feel guilty and they minimize. So the same dynamic can sometimes happen even in the clinical community with their patients. So the way I address it as a clinician is I say, look, I want to, and what I say to my patients is that, you know what, this test I just did, this pen and paper test, something's not right. You know, there's a memory issue. I go through them, what I think's going on. And I can't tell with you sitting here with me if you're safe to drive or not, but I know that your performance tells me that there might be a problem. So what I'm going to do is I'm going to refer you to a driving safety test. Okay. This is going to involve you doing some simulated activities, not in a car. And depending on how that goes, you might then do a car test. And I'm telling you this not to put you through anxiety unnecessarily, but neither you nor I want to deal with what would happen if something were to occur where you hit somebody because of this cognitive issue you have, or you got into an accident or hurt yourself. God forbid that happen. We don't want to see that happen. Most people will agree with that. If they're not even aware there's a problem, then they definitely need to go through this process. And they may even not even need to go through the process. We just got to figure out a way to take away the keys. But I try to have the family members lean on me to be the bad guy, where I bring it up and I address it. And I know this is not the rule. This is not usually what happens. I wish this was the way it happened. If we could change the way we deliver dementia care for people within the medical community, a lot of these burdens could be lifted from the families and supported by the clinical community. And that's just not the way it normally goes.
Yeah. Really good advice. Thank you for talking about that. I want to mix it up a little bit and really talk. A lot of my audience is younger onset. So, I have sons and daughters, but I also have spouses that are younger. And so I know in your practice, you probably deal with a lot of differing age groups. And, one of the difficulties that a young wife or husband has, really even in around support groups, is, relating to the people. So, meaning finding a support group where they might find, people their age or people in their situation. They may be the sandwich generation, still working, maybe even raising small children. So do you see that in your practice where you are coaching, the wife of an early onset Alzheimer's disease or something? And what do you advise them to do in getting support if they don't want to go to a support group with 80-year-olds?
I'm really glad you brought this up. I don't know whether we're truly seeing a rapid escalation in the numbers of early onset dementia. It could be that we're more aware of it, but we definitely see a lot of this as well. So I'm very familiar with this dynamic. You could have a loved one in their 50s, or 40s even. You may be still raising your kids. I've had numerous patients in this situation. So oftentimes the spouse, what I often will say, because you're right, the dynamics are different if it's your parent or if it's your parent versus if it's your spouse, and especially if you're young with your spouse and your kids are still young, it's a very different dynamic. So I will say that, again, it probably is a little different from chapter to chapter around the country and where the resources are. But the Alzheimer's Association in our state, which is now a regional chapter of the Alzheimer's Association for New England, we have an early onset Alzheimer's disease support groups, and actually groups, not group. Run by a clinician who is an expert with this population. And that's where I send people if they're willing to do it, because they're going to find peers who are in a very similar and really challenging situation. I will also say that, well, Zoom helps now, but up until Zoom, when this was all done in person, it was very hard to get people to give up time, because who's going to watch their loved one and then their kids? And, it's just very hard. Now with Zoom, it's much, much easier. And there's a lot of flexibility on when these groups meet and so forth. But I would say that would be one thing I would definitely recommend where to get support from. I think reading this book overall really doesn't matter whether you're a spouse of a person in their 40s or whether you're got a mom who's 90 and it's an adult parent. I think a lot of the lessons are very similar. But the challenges of losing someone in front of your eyes in what you thought was not just your quote unquote later golden years, but was in the prime of your life, and you've got kids to raise, it is really, really challenging. And I think even not more so, but equally so, and in a different way, spouse caregivers with early onset really need to get support from someone outside of the family. They really need someone to guide them through every step of the journey. And there's a colleague of mine, she's now a colleague of mine, but at one point about 7 to 10 years ago, she was a woman in her 30s, maybe early 40s, who had a loved one spouse with early onset frontotemporal dementia. And she was an unbelievably heroic caregiver, has also cared for parents with dementia. And the stories she tells about that experience truly are unique to someone who's younger with a spouse. So I agree with you wholeheartedly. Individual counseling around this with someone who's really an expert in dementia care as a therapist, as well as the support group with the similar population is really important.
Yes, and for our listeners, there's a 24-hour hotline that the Alzheimer's Association has. They'd be glad to refer you to the different support groups, either online or locally in the area where you live. There are multiple types of support groups available for all ages. They're on Facebook, they're online, and they're in person. So please use that resource for your benefit. But, one of the things that I find important, and I'm so glad that we're covering all of these areas about your book, and I'm talking to co-author Dr. Brent Forrester from The Complete Family Guide to Dementia. There's an area here that I want to encourage my listeners to get the book because they really delve into caring smarter, not harder. And if there's one thing as a coach that families ask me over and over again is about those hard decisions and about resources. So tell us about this chapter of the book, Caring Smarter, Not Harder, Dr. Forrester.
So I think that, again, Tom came up with the line. He's a genius when it comes to words. You can think about this in your own professional work or anything you do, where sometimes we do a lot of things that are making us feel good or seem like they're the right things to do at the moment, but they're actually just making things worse. And so a lot of this is being very proactive about really getting the help that you need to do a better job. And so one way to care smarter than harder is to think about what are the goals of the care for your loved one that you really have. And sometimes, and we talk about this in the book, but I think the two concepts are related, that we often will think that the goals that we have are the goals that our parents told us when they were younger, like, don't ever put me in a nursing home. I always want to be in my own home, or I just want them to be happy. I think instead of that, maybe take a step back and say, well, what is really most important in this situation for me and my own health and well-being, and frankly, for my loved ones' health and well-being? And depending on the state of illness, it may be that the person's not able to express themselves in words, but there's feelings that they can still understand. And I think it's really important that the relationship that you had with your parent, it's gonna, as we talked about, be different than it was. It doesn't have to be perfect. It has to be good enough. And you do want to make sure that you understand what your goals are, and also, in as much as your loved one can express them, what their goals are in terms of day-to-day life. So the other part that I really think about with caring smarter, not harder, is you want to be able to spend time with your loved one in ways that you and they find meaningful. And the only way to do that is really to have help. And I think it's really hard. I struggled over the years with families when I didn't have this concept fully worked out. And I didn't realize the state of denial and minimization a lot of families were in. But, if you could send your loved one to a program, a social day program during the daytime, so that they are engaged in activities that actually are meaningful to them. They develop some social relationships. And frankly, as importantly, you have time to get your work done, to do errands, to sleep, to take care of yourself, to socially interact with other people. If you're living with a loved one dementia as an adult child or a spouse, or visit frequently and you're always on the hook, and you don't do anything that's outside of direct care, that's not going to make for a smart, caring approach. The way to care smarter is really to think about what are the needs that they have and what are the needs that you have, and come up with some strategies of enlisting support. Again, social day programs is one way. Bringing in help, it could be a companion or a friend type of person, or really talking with someone at the Alzheimer's Association to get resources like you are, which is a dementia coach, to kind of guide people through the journey and what they need to do. So like, the one last thing I'll say about this is, what's not smart about caring is, and I'll give the example of, that often happens in the medical profession when physicians experience medical issues. They think that they can care for themselves, or a therapist who thinks they can be their own therapist, or they think they can enlist a family member as their therapist. You need outside professional help for this, no matter how trained and experienced you are. Same thing for families. You may be an amazing caregiver who is uniquely in your mind, knows how to get mom to shower without hassle. But what is the cost of that day in and day out to your loved one with the illness and to you? So caring smarter is about setting up a situation so you don't always have to be the person on call doing this. Do it some of the time. Don't do it all the time. Or figure out what's right for you. And that's the way I think about this phrase, caring smarter, not harder. It's not just thinking about the person, it's also thinking about what your needs are as well.
So here's a question that everyone wants to ask a psychiatrist, right? When is it okay to lie to your parent or your loved one, spouse that has dementia?
This comes up because people feel guilty, and they also wonder about, just philosophically, is this an ethical breach? Is this something which is disrupting my relationship with my loved one? I know for years there have been this term that's been thrown around in publications called therapeutic fiblets. I think they refer to what you just said, lying. I think lying carries a connotation of something that's really mean and nasty and we should never do. The way I think about this whole concept is, if you understand the nature of your loved one's cognitive problems, you can come up with the best way to communicate with them when you need them to either decide something or do something, or how to shield or protect them from something that might cause undue harm. So as an example, if your loved one has the form of dementia we call Alzheimer's disease, where someone's unable to learn new things, they're going to rapidly forget anything you told them. So what you're talking to them about now is about now. 5 minutes from now, new reality takes hold. They don't remember the conversation. They repeat themselves. If you're going to tell them something which might in the moment distress them, and they're going to forget about it 5 minutes later, and then you're going to tell them again, and it's going to distress them. Like, don't you remember that your brother Joe died last week? And then they get upset. And then a few minutes later, they don't remember the conversation. You remind them again. So sometimes, again, and that's an extreme example, because not sharing news of the death of a loved one is really hard. But you would always share that news when someone's earlier on in the illness and they can retain the information and they're able to cope with the grief that they're going through. But the later you are in the illness and they can't even retain new information, you have to ask yourself, what is the potential benefit of this? So the therapeutic part of the fiblet, if you will, is what's right for the person based on their stage of illness, what they can comprehend, the way, how's it going to make them feel? How's it going to impact them on a day-to-day basis? So when I think about lying, I that's what I think about. And the only way to deal with this, I think, is to talk about it with others. Like, share this story with other caregivers. Make sure you know you're not in this alone, and they've done this before, and they have some strategies. and they have talked to you about what works and what doesn't work, and then you'll figure out when and when not to, employ this tactic.
So before we move on and before we close today, I want to highlight some of the important points in the book that I want my audience to know about, because I do feel like of the many books that I have read that this is really a resource. It's a reference manual, the complete family guide to dementia. It's something you would go back to over and over again. It's not something that maybe you would look at one time, but you could pick it up throughout the course and the stages. But I want to highlight a number of things that are in the book for my listening audience, and that is to know the difference, right? Dementia and aging are different, right? Get a clear diagnosis. So both of the authors really believe in getting a clear diagnosis. Reframing the relationship. How important that is, no matter whether it's a parent, a brother, a sister, or a spouse. You really have to look at that relationship different. Care smarter and not harder. Dr. Forrester just went over that. When truth hurts, consider kindness. That's another area. These are hard questions that many, many families ask me, and they address it in this guide. And then plan early for later, as well as you matter too. And I think Dr. Forrester has brilliantly, hit on that. Is there a particular section or sections in the book that really touch your heart or mean most to you about this guide?
Well, one thing I wanted to reflect on, all of those 7 points that you just made are critical. And the other thing I just want to recognize is that you reference coming back to this guide, multiple times. We know these strategies work and they're really important, but I also know that implementing them is very difficult. It's one thing to know something intellectually. Yeah, that makes a lot of sense, Dr. Forrester. Yeah, I could do that. But in the moment, emotionally, like you said, whether it's through the lying, the therapeutic fiblets, or whether it's the relationship change, but in the moment, it's emotionally hard to do this, which is why you can't do this alone. I would say in terms of the part of the book, I don't think there's one part of the book, but the part I guess that I want to highlight is it's not what to do in the middle or the end stages, but it's to really highlight to the world that's going to be facing an aging population that until we come up with a truly disease-modifying treatment or a clear-cut way to prevent this illness, we have to be on the lookout for it. We have to go find the expert guidance we need to get the diagnosis, and we need to seek out support as we help our loved ones through the journey. So I think that's the holistic approach that I really think we take in this book. But getting this answer early on and not minimizing the problem and not over dramatizing it either. And then I guess the last thing I'll say is I think one of the reasons that sustained me in this field for 30 years, I've seen so many people thrive despite the diagnosis. I've seen them be happy, live lives that they want to, that are safe, but that are engaging socially and cognitively, that this illness could go on for years and years and years. We don't want to walk away from someone with this illness. We want to embrace this person, and we want to help them live the best lives that they can.
In the final section of the book, you address the later stages and big decisions. How can caregivers prepare themselves emotionally for the later stages?
I think the way to prepare is to continue, again, being proactive and not reactive. So there's the emotional part, and then there's the practical part. The practical part, like healthcare proxies and the financial aspects of things, and we didn't even get into it and don't have time now, but there is a section in the book about another guilt provoker, if you will, is a decision around long-term care. For some, it's the guilt around bringing in someone as a home health aide or a companion, but there's a lot of guilt around that. So I think to prepare for this is really to realize something really fundamental about being a caregiver, which is that you're going through grief in caring for someone with dementia, whether it's your spouse, your sibling, or your parent. You're going through the grieving process where you're seeing in real time over a long period of time. Someone you knew and loved so well changing, and you're losing them, and it's staring you in the face. And I think the way to prepare for that emotionally is to really, go see a trained clinician who's a therapist to talk about grief. No one who goes through caregiving for a loved one does not experience grief. And there are healthy ways of experiencing grief that have different stages, like denial and shock and anger and fear and sadness and depression, and then coming out of it and actually resolving and finding a way forward and accepting. But there's so many places on that grief pathway where things can go awry. And so being proactive about getting help to deal with the grief that you're going through will prepare you for emotionally what comes, down the road.
Well, Dr. Forrester, I want to thank you for joining me on the podcast today. I hope you'll consider coming back. We have only touched the tip of the iceberg, I know. This is a very valuable resource. Any last thoughts to the audience?
This is in our book a little bit, and it continues to, I continue to think about this all the time. I mentioned how common and prevalent dementia is, and I mentioned how much of a delay in diagnosis there is, and how many people with this condition aren't even diagnosed. But the only way we're going to address this is to come together as a society and as a medical community to reach earlier into the disease process, get people diagnosed earlier, get people into early treatment, support families through the journey of care, and bring the world of research, clinical care, and education together as one. Right now, we're about 40 years behind where the cancer field is, at least in the treatments that we have and the way we diagnose people and the stigma related to this illness. And when you get a diagnosis of cancer, it starts by doing screening in primary care, and then there's a pathway. Right now, we don't have that pathway for dementia. And we're just starting to have treatments that might actually make a big difference in terms of disease course. The behavioral symptoms of dementia that I mentioned before are universal over the course of this illness. And there's so much that we can do to reduce the anxiety and the depression and the paranoia and the agitation that goes along with this illness. I want to reemphasize that this is a family disease, and to recognize that if you're a caregiver, that you need a lot of help in managing this, that you cannot possibly do this yourself. I can say from experience, I cannot do this by myself. I have siblings, I have a care team, etc. So I think if you can embrace this illness and address the issues that we talk a lot about in this book, and don't minimize and deny and delay, I think you and your loved one with dementia will be a lot better off, despite the challenges that we know this illness causes.
For those listening, you can find the complete family guide to dementia wherever books are sold. I got mine on Amazon. I want you to remember today that this podcast is here to serve you on the dementia journey. Please get the book. Please read the resources. Until next time, this is Dawn Platt. Make it a memorable day.
Thank you for joining us for the Disappearing Mind podcast. We hope it's helped you find clarity and support along your journey. Be sure to subscribe to never miss an episode, visit our website to suggest future topics, and share the podcast with friends and family.